Today talking about somatic symptom and dissociative disorders. Here we have the learning objectives as always. Something I added to the reviews for chapter 6 and 7 is even adding in what learning objective the question comes from, just in case you're reading through your book, you are having trouble finding it. I don't know, I thought it could be helpful. So that's in there now too, for 6 and 7, and whenever I get up 8 is when you'll have the 8. Okay, so let's just start off with what are somatic symptom disorders. These are formally understood as other neurotic symptom disorders, but when you're thinking of somatic symptoms, I want you to think physical bodily functioning symptoms. So what's going on in individuals' bodies that are potentially hurting, that are potentially making them tense. I mean, any negative feeling that you can feel tingles. You can have seizures, you can have stomach problems, many different things, but they all have a physical root in the symptomatology. And what we're going to be talking about today are both the somatic symptoms and also dissociative disorders. Again, you have here just a breakdown. Soma does equal body, which is why you should be thinking of body symptoms when you're thinking of somatic symptoms. Somatic symptoms and those related disorders are categorized together in the DSM-5. And these are very often difficult to diagnose because a lot of times you would go to a medical doctor for the symptoms that a person is experiencing, whether that be headaches, whether that be nausea, whether that be, to the more extreme seizures. So I think most of you are just thinking to yourself, who would you go to? You would probably go to a neurologist. You would probably go to a medical doctor. But really, if it's a somatic symptom disorder, the best way to treat it and the root problem is from a source of stress, is from a sense of anxiety, depression, need for attention, whatever it may be, depends on the disorder and the person, of course. But the way that we often find these is because these people have gone to many doctors, and unfortunately, those doctors can't help them, those medical professionals, and they say, okay, well, it can't be medically, physically explained. The medications that we're giving you, whatever it is, it's not working, and they send you over to a psychologist. So that's most often how these disorders are found. There's a number of disorders that we're going to be going over today, and they are listed here. Those are the most important and also the most observed. All of these, though, are pretty rare compared to other disorders that we're going to be talking about in here. Good morning. Okay, so starting off with somatic symptom disorder, what this actually included, and what you might have heard before, is hypochondriasis, like that you're being a hypochondriac. Has anyone heard that? Just in their regular day-to-day life. So that's people, maybe if you've ever called someone a hypochondriac, it's people who are always saying like, oh, I twisted my ankle and it's really sore, and they just tripped. Or they say like, oh, I have these terrible stomach pains, I must have stomach cancer, and it's like, they just haven't eaten very good food in the last few hours. Or they're like, oh, I'm feeling a little hot, I must have a fever, and they just really stepped outside and it's hot outside. Yes?
Would you characterize the hypochondriac as somebody who self-diagnoses himself all the time on the internet?
Often that does happen. Those people who would be called hypochondriacs would definitely do that as well, because they would take one very small symptom, like a little headache, happens to all of us, probably because you just didn't drink water, and they go Google themselves on the internet, Google it on the internet, and they think they have a tumor. Yeah, that's a great example. Thank you, Kenneth. Here's a pen. Oh, I'm saying they can't see me, but hopefully they can hear me. Okay. What also included in this big jumble of symptoms that they just decided to group together in the DSM-5 is the pre-existing somatic symptom disorder. Somatization disorder is another way of saying it. And those are people who although they are feeling stressed, although they are feeling anxiety, although they're feeling sad, they feel it in their body instead. So instead of, having maybe some mental pain and mental stress, they, maybe aren't in touch with those thoughts at all, don't recognize that they're there at all, and then just feel some wheezy, like woozy feelings. Or they feel a lot of tension and pain in their back. That's a really big one. Or in their neck is another, big one. So those are people, again, who likely do have significant stressors, likely do have some thoughts, but they're very, very subconscious to them. They're not able to access those. And the way that their body really understands and deals with that type of stressor is through bodily pain, bodily experiences. And then finally, the third one that they, what's your question?
What was it? Why are there hypochondriacs? Why do you think it develops to them to be so?
Why are people a little bit like that? One of the not so nice reasons that the book gives and that I've heard before is that these people are like, and this is definitely a very psychoanalytic way of thinking, is that they're like less evolved in their ability to understand their psyche. I think that's like very stigmatizing and not very nice. I think it's just that most people cope as best as they can. And for some people, that looks like, not accessing thoughts, but just feeling the pain in their bodily systems. But I don't have like an exact cause, we definitely don't know why some people are the way they are. But those are the reasons I've heard. None of them are exactly, but they're, I think, pretty close guesses.
I think I don't know, sometimes because we have a family member who's like that, and she's just trying to bring attention to herself all the time with this stuff.
Yeah, so we will talk about attention seeking for these disorders as well. That definitely could be part of it for hypochondriacs. I think more it's probably stemming from their anxiety, but attention seeking definitely is connected to this as well. Yeah, so good question. I'm really sorry. It's been like 2 minutes. I'm so sorry because I've known you for a while. And Sarah.
Yeah.
Sometimes it just blanks on some people. Yes.
Do you think it could be like if you're raised with I don't know, I was raised with a mom who's kind of a hypochondriac, and it's always like every time something happened, it was never, oh, you're fine. It's always like, oh, you might be dying.
Yeah.
Do you think that's something that could play into that?
Definitely. And we're going to talk about Mann-Huntington's by proxy, which, that's like the most extreme, not saying that your mom did that at all. But yes, that's often very learned behaviors of just learning to worry about your body can definitely look like this, and then turn into a somatic symptom disorder. Good questions and good thoughts. Okay, so we've hit all of these. Now, just again, hitting on the causes, which you were kind of just talking about. We hit on already, people who already just naturally tend to be anxious and maybe have difficulty expressing themselves or a little less involved in their understanding of their own psyches. What it also could be is that individuals who really do have a number of physical illnesses, like legitimate diagnosable physical illnesses, they do tend to be more likely to be diagnosed with this later in life as well, somatic symptom disorders, because they've had the experience of, well, I did have this illness before, I did have this disease before, and they're worrying about it. So that does put them at greater risk for experiencing this. Also, people who kind of have a tendency to become very absorbed in worries, kind of like what you were thinking of, kind of when you were talking about people who love WebMD. They kind of just get sucked into that black hole. So that kind of has a relation. Also, people who have alexithymia. For those people who have difficulty identifying words in general. So people who are severely tongue-tied, I guess you could say. Not that they don't have the words or have the understanding, but just really don't have the words to express themselves. They also. And then people just who have negative affect and just have high anxiety or high depression levels are just more likely to experience this because already their body is struggling with whatever they're anxious or depressed about. And then on top of that, sometimes they just get emotionally flooded, right? Like it's just too much information. There's not enough mental capacity for them to deal with those thoughts and feelings. So their body starts dealing with it in a way that their body can express that emotional pain in a physical way. Does that make sense? Yeah.
Can you please say that?
Alexithymia?
Thank you.
Mm-hmm. No problem. It's for people who have trouble finding words.
I'm just trying to remember how you
Oh,
pronounce it.
yeah, alexithymia. Mm-hmm. Any other questions? Okay. So, here's the big question. Maybe you've been thinking about this to yourself. Like, what if these people really do just have more physical problems, right? Like, what if they really do just have, like, irritable bowel syndrome, or they have a tendency for migraines, or they have a bad back, right? Like, those are all legitimate questions. And sometimes those also don't have a medical cause. Like, medical doctors can't always help people with back pain. Like, sometimes they just can't for whatever reason. I'm not a medical doctor, so I don't know why they can't, but they just can't. But it does have a physical root. So a lot of times we ask people to do a body log. So what that is that during the times of day that the person is asked by their psychologist, like it could be in the morning, every few hours, just write down what your body is experiencing. So they could be like, well, I just woke up and there's a pain in my lower back and my legs are stiff, which like lots of people with back problems have, especially when they're first waking up. A lot of people have a lot of stiffness. But maybe someone who does meet criteria for somatic symptom disorder is going to be endorsing that pain much more often. And that is what we're finding consistently throughout the research, is that like with those body log entries, whether it's about their skin, their muscles, their heart, their stomach, their breathing, there's so many different, options here, that those specific sensations that they could be endorsing, people who meet this criteria really do experience the pain more often. And just important to note, I'm not trying to take away from anyone's pain. Like people who have somatic symptom disorders really do feel physical pain. Like it's not to say like, oh, their pain is less or they don't really feel it because it's coming from a mental health issue instead of a physical health issue. They really do feel that pain very, very acutely. Sometimes, like I said, even more so. But of course, it is a chicken and the egg kind of situation. Like, is this person really just someone who tends to be sicker more often, right? And they just have like worse body symptoms because they're made the way they are and that's just their environment? Or do they have really a lot of mental health issues that are exacerbating those physical symptoms for them? Does that make sense? Yes.
Is it possible that they always think this type of way that it actually could go that route?
Mm-hmm.
Because I met some people that actually have some.
Definitely. Like you could be so worried about, a headache or worried about a migraine, which I mean is something to be afraid of. Those can be very painful, very debilitating, right? And then you can work yourself into such a stress that you do get a migraine. That definitely could happen. And I think that probably happens pretty often, especially with the nature of stress, if we've talked about that mind-body connection. For people with back pain, a huge connection. There's like this very preeminent psychologist who focuses on specifically back pain and says the root of back pain is anxiety and stress. And then, you can be stressed out about your back and feeling bad and feeling like you can't do all the things you used to be able to do. And then the stress builds up and your back pain gets worse. I know, such a shame. You've heard of that happening in the medical field? Yeah, because it's pretty common. I think it's very well accepted, the connection, but especially back pain and anxiety. No.
Brian.
Brian,
Yeah.
Hunda, right?
Yeah.
Sorry. You know, I miss a few weeks and I've got 2 classes, I get messed up. Kenna,
Sorry,
it's okay.
but the body log you said when they put down and presented to your psychologist. Does the DSM-5 regulate, like it does anxiety, like you get 7 of these things?
It's not about, we're gonna get to the criteria, it's not about the actual, like how many physical symptoms they have or how often. It's about like the thinking processes, more so. I mean, someone who has a somatic symptom disorder could, experience it, twice a day, and someone who has the same disorder could have it, 7 times, 10 times a day. It's not about that as far as the criteria, but we're gonna get to the criteria. Yeah, no problem. Yeah.
Yeah, I think with a lot of the patients that we see, the place I work at, like a lot of them, I've had to deal with them, like, is it with headaches and stuff like that? Like, I've had to, now I'm getting in a pattern where, like, every time I'm assessing them, they're like, okay, yeah, because, like, how is your stress level right now? Like, what has happened, like, within these days? And they're
That's
like,
awesome.
oh, yeah, like, we purchased this house, or I got moved up, or whatever, and
That's so good. That's really great that you're asking those questions. So maybe you're kind of thinking along the lines of like, those people didn't even recognize that they were stressors. They kind of like were pushing this to the side, just moving forward with their lives as we so often do, not stopping to think of, oh, this is really bothering me. This is creating a lot of stress in my life.
Yeah, because we assess them like physically, but then if their stress levels are higher than what, they're like, we're not getting better, better, but then you're not gonna get better because your stress levels are so high. You need to be able to cope with that.
Yeah, for sure. Good point. Thank you for sharing that. Okay. What else did I want to share about these? Another point that I don't know, I mean, I did say it in so many words, is that when you're seeing these body logs, often is when you can pick up on this, is that like catastrophizing tendency. Like the person who has, a physical disorder when they're, have an understanding that there's a physical source to the pain or discomfort that they're feeling, they're not going to jump to conclusions on this body log about like, oh, I know I've felt this before and it's probably going to get worse and it's probably, gonna like put me out of work for the next few days. Like the comments that people make about the pain and where they're feeling it, you do see a lot more catastrophizing, right? In somatic symptom disorders. And then also, sorry, one more thing, you just also want to be cognizant of like the person's individual sensitivity. Like we talk, I think, a lot about like your pain tolerance. You can think about that here as far as like your tolerance for discomfort in your body, whether that's quite high or whether that's quite low. Again, for people with this type of disorder, usually their sensitivity is, very, very low, and one minor little cut, scrape, discomfort could trigger them. So what we do is we use cognitive behavioral treatments. I'm actually seeing an individual right now for this type of disorder. It's quite interesting, and I think it really can go in 2 ways. People can feel validated and feel like there's finally an answer for the pain that they're experiencing and haven't had an answer for it. Or they can feel really invalidated and feel really terrible about the fact that someone is just trying to talk them out of their pain. I think it very much depends on the person and the type of therapy you're doing and the connection that you can make to your client. Hopefully you're able to create a therapeutic alliance that's strong enough that they can handle hearing this and be supported and try to work towards the goal of physically feeling less pain. So just something interesting to note about this. So a number of the cognitive options that you have, first and foremost, is relaxation training, meditation, mindfulness exercises. visualizing a safer space, a calmer space, a peaceful space. Everyone has, different visualizations that they prefer, whether it's the water, whether it's mountains, and trying to put themselves in that pain-free psychic place. Then also, validation, kind of like what we have in really all of our therapeutic realms, is just like validating the experience of the person, allowing them to feel heard and understood. Because likely, especially someone with a somatic symptom disorder, they've heard from a lot of previous medical doctors, there's nothing wrong, you shouldn't be feeling anything. So just hearing from a professional that, I'm sure this is incredibly painful, that this is very stressful on your life, that this really hurts and is very debilitating to you, can be healing. Creating, activity logs and daily activities and routines to help them just get up out of bed, to help them, validate, of course, the experiences that they're having, but then also to take from a very healthy perspective of, okay, I'm feeling this pain, but where is the level of pain for me now? How can I try to lower this level of pain by relaxing my body? And just creating a log and maybe doing some thought activities as well with that, as far as like, what are my thoughts saying about this pain? If my thoughts are saying, I can't deal with this, I'm going to die, this is terrible, why don't I try to change these thoughts to say, this pain is manageable to me. I am a strong person. I can handle this, and I can still go about my day, even though I'm feeling a significant amount of pain. And then we have, cognitive restructuring, which I kind of talked about just now already with that, self-talk of saying, I am a strong person, this is something I can do. And then the no pain behaviors of how is it that they can treat their body? How is it that they can move? How is it that they can relax to, again, self-soothe, to bring themselves down from that cliff of pain that they're experiencing. And then there is, of course, medical management. Like, there are still medications that people can take, even if they are experiencing these physical pains through a more psychological basis. So it is possible to get some prescriptions that could be beneficial. So now we've got illness anxiety disorder, which, as we kind of already talked about, hypochondriasis, that's what it was previously known as, but not anymore. What they have now is for the 25% of people who met criteria for hypochondriasis, they now be lumped into likely illness anxiety disorder. And then the remaining 75% for people who met criteria for hypochondriasis will be lumped into the somatic symptom disorder. And I'm going to tell you how to differentiate between illness anxiety disorder and somatic symptom disorder. But just know they are different for now. And now, just here, hypochondriasis, what is the differential criteria, right? What you want to be looking for is the fear, okay? That fear of things getting worse. So it's that actual, like, not necessarily people who have hypochondriasis, illness, anxiety disorder are like really feeling it, right? Like, they're not necessarily having those somatic symptoms. It's more about the fear of having those somatic symptoms. You feel me? I don't know if I said that clearly. Yes.
Yeah, I agree.
Okay, cool. Well, great. Juan got it. So the way to differentiate, again, I just want to make sure, because this is important stuff, is for people who have illness anxiety disorder, they are not actually experiencing those symptoms. They might in the future, but it's about the fear. So, like what you were saying, Kenneth. Where I am? There we are. I said what? I did it again. I haven't done it in a long time.
I'm proud of you.
Like what you were saying, Kenneth. So if the person is just like not actually feeling any pain, and then they go onto WebMD and they're like, well, it could be this, I'm worried about this, my dad once had this, my friend had this, then it's illness anxiety disorder, okay? But if they really are feeling pain and they like really are already having a headache or already having a lot of back pain or stomach problems or skin tightness, who knows what it could be, whatever complaint that they might have, then they likely fall into the criteria for somatic symptom disorder because they really are experiencing those symptoms. So there it is. Just that breakdown again of like 75% who would have been labeled as a hypochondriac, likely are going to go to a somatic symptom disorder, and then for that 25% who really are not feeling that pain are going to go into illness anxiety. So now let's talk about a different one, conversion disorder. So this is a very, very interesting one. Historically, it was one of several disorders that were lumped into hysteria. So people who were just assumed to be like totally crazy, not able to control themselves at all, had a lot of stigma around hysteria. But what this is looking at the neurological symptoms in the absence of a neurological diagnosis. I quickly mentioned one of the possibilities for someone to experience is seizures. That likely would be someone who's experiencing conversion disorder. Freud believed that these types of people who had potentially conversion disorder were likely those sexually suppressed people in the world, and that their bodies were revolting against them because of their sexual desires were not being met. We don't think that's the reason now, but it is very intriguing because, like, I think, who was it? Janet mentioned, we are seeing a lot of links to potentially attention-seeking behaviors. So let's watch this video and then we'll talk about it some more.
Dr. Jennifer McVick is a pediatric neurologist. She's been seeing patients in this case since October. Good morning.
Good morning.
Explain to me what conversion disorder is, why so many women are affected, and why you think that this is the cause rather than environmental disorders that is speculated.
Conversion disorder is just the manifestation of psychological symptoms in a physical form. So usually there's a stressor that's the onset. Somebody has either a lifetime of many stressors that build up or one individual stressor, and it kind of brings that out in a physical form. So people may have seizures or fainting spells. They can have blindness, tics, loss of motor control where you can't move a leg or an arm, and that's how it just kind of comes out.
What are the psychological disorders that might cause?
Some anxiety, depression, anything, yeah.
And why do you rule out environmental disorder as a possible?
Well, we've been working very closely with the U.S. State Department of Health, Dr. Greg Young. They've done full testing of the school, the groundwater, the soil, the environment around the school. And the CDC has been brought in, they've been having discussions with them. So from all that we've known, all of this has been clear.
You just mentioned in treating a number of these kids since October. What are some, they said anxiety, but what are some of the specific stresses that you believe they told you about in their lives that led you to this diagnosis?
I can't talk about specific only because of HIPAA violations, but I can say that I'm treating some of them even since the summer. But it can be as easy as familial divorces within the family or something else like that.
How close are all of these kids? I mean, they're all facing the same stresses, but there's this large group all having it right now.
They don't all have the same stress. And you can imagine as a 16, 17-year-old child, or a young adult, I should say, there are several stressors within the school situation. And I should also mention that we do suspect that usually with conversion disorder, this is actually mass psychogenic illness as opposed to conversion disorder because of the fact that there's so many people involved. This is what we are believing. Usually with that, there's an index case. So we do believe that there's maybe one individual that may have true motor symptoms or have developed a conversion disorder that's precipitated the entire thing.
What is it, Erin Brockovich is making what point, and she's sending people there to do what?
I believe that she has found information about a train derailment that happened years ago, and there was a feeling that there was contamination that wasn't properly disposed of. I believe that.
And you said earlier, you don't think that that is a possible cause.
I'm unsure if that actually happened in train derailment. I'm sure that happened in the history, and if there's contamination, I don't believe that this is the cause of this particular symptomatology with these particular girls.
Because you talked to them and treated them.
I've treated 10 of them.
Thank you, Dr. Jennifer. Thanks for coming in.
Okay, so here you heard her talking about the symptomatology, the experiences that these girls were having in New York, how there was, a bunch of them all in one area. And I think I mentioned this, I don't know if you've heard the lecture yet, but like a lot of times with suicidality, similar to conversion disorder, you can see one person with it, and in suicide who has made an attempt or a completion. And then it does increase the likelihood of people around them also attempting. So similar to conversion disorder, this group of girls, maybe like she said, there was one person who truly started having, some motoric differences or difficulties, whatever it was. And then all these other girls kind of started to have symptoms that were similar, whether it was the verbal outbursts, the tics. I think she mentioned motoric differences that these girls were having. So with that, they then developed conversion disorder. What else did I want to note about that? Any questions on it? Yes.
What did, she mentioned the contamination, what does that have to do with?
So she was saying, like, with any of these somatic disorders, you do want to check if there really is a medical, reason for the experiences that they're having. Like, that is very, very important to do. So that's what she was talking about, that like there could have been some contamination in the water that could have been contributing to someone having motoric, whatever was going on for those girls, differences, and then there would be like a physical source. So if they changed the water, hypothetically, if it was contaminated, they cleaned it, then they shouldn't be having these motoric symptoms. But then what you really can do is you tell them the water's been changed and they're still having them, it's conversion disorder or likely conversion disorder. A really great one, if you're interested about this, it's just a movie that's on Netflix right now, is Brain on Fire.
Oh, yeah.
Has anyone seen that already? So they were throwing out schizophrenia. You could have, I think, also thrown out conversion disorder for her. That was someone, sorry to, this is not it's not going to ruin the movie for you. There was a physical reason why she was having these symptoms. Like there was something about her brain, I don't know, something was swelling, whatever it was. And for a long time, though, they went to many doctors and they were like, there's nothing wrong with you. There's nothing wrong with you. It has to be psychologically based. They were throwing out schizophrenia because of her combination of symptoms. But if they were less extreme, it could have been conversion disorder. And so it's just a cool movie. Yeah, John.
So basically, conversion disorder has to be purely psychological and experience-based and emotionally.
Yeah.
So never.
There cannot be a physical reason. It can't be that their brain is swelling. It can't be that there's some bacterial illness. And yeah, that kind of is what you need for the criteria. And then is it Alyssa with an I or Y? Y, thank you. Okay. So these are possibilities for any of the symptomatology of someone with conversion disorder. Here also you have it listed out as well. Again, it could be visual or auditory symptoms. They could be, very similar to schizophrenia, which is also probably why this is often misdiagnosed and really is hard to parse out. But they can be, experiencing some dots. If anyone's had a really bad migraine, you can see some twinkling lights, flashing lights. I don't know if you only experienced it. I've had a migraine, so I know what this is. But you can have these sparkling lights that like kind of like just circle around. You can also have like auditory symptoms of like ringing in your ears. You can be hearing things that other people don't hear, and then people really can go down a rabbit hole and think that you have hallucinations or something like that. The motor symptoms, again, it could be a wide range of symptoms. You've heard that the doctors speak about that in the video, what that can look like. It could be tics, it could be losing, the ability to move the arm or the leg or whatever it is. Or it could be that they like don't have control and that they're shaking a lot. Seizures, and then you can hit on all three of these, just one of them, whatever it is, two, any combination. So again, it is really important because it's a very, very difficult diagnosis to give. You have to, I would say, if you are ethically working within the mental health field, you really have to include a medical professional in the diagnosis of this, because you are not competent enough to say to someone there is no medical basis for the symptoms that you are experiencing. So you have to refer them to someone else, whether that's a neurologist, whether that's a family practitioner, depends kind of on the symptomatology that they are showing. But you really do, you have to include someone else in this process of diagnosis. What we do see is things that are like helpful to getting a diagnosis is that the symptoms will decrease or will be removed under hypnosis. Of course, you have to be trained in hypnosis. Most psychologists are not, but you can get people into a hypnotic state that allows them to stop feeling those feelings. And if they really were physically based in a hypnotic state, even they would still be feeling those symptoms. Yes. Yes, I was gonna get that. Yeah, and then narcosis is like really drugging them up. If this really was a physical symptom, like you would need much more specified drugs that should have worked maybe a while ago when they were first trying to diagnose this. So.
I don't understand like how it starts.
How does it start?
Like,
Yeah.
for anyone, I don't understand how you just start having seizures and there's no reason behind it or not
Yeah.
able to move like part of your body.
It's a really, really scary thing because literally people can just wake up with this. Like they can just one day wake up and not be able to move their arm. It's really crazy. It's really weird. Yeah. Like we have, talked about some reasons of like it could be that stress that's like, not being realized for them and not being addressed. But yeah. We have other reasons, like in the future, again, like some maybe potential attention-seeking behaviors, maybe like just depression or wanting, connection from people or wanting concern. But yeah, it can be that someone just like has no symptoms before, is like functioning in society, and then they just drop and have a seizure, and there's no medical reason. And that can unfortunately just happen. It's really scary. Will you tell me your name again? Thank you.
So like if that does happen, like won't they run the risk of like people just thinking that they're like not like oh, you're not feeling that, like it's all in your head?
Well, all of these disorders are really, really rare. And medical professionals do take seriously when someone has a seizure. Like that is definitely not the first thing that they think of, like, oh, it's
I'm
psychologically
saying,
based.
Say because it said, I don't know if this one was in early adolescence, but like if you go to your parents and like, I don't know, say, Mom, I can't feel my arm, or like, and they're actually like feeling these things, but their parents are like.
Well, I think that would kind of be like a parent issue. Of like, why don't you believe your child? That I think would be like more of the problem there. But most of the time when people do experience a seizure, there is a physical reason, like they have like epilepsy or there's like a pinched nerve and that's why they're experiencing pain, or their arm fell asleep because I don't know why, right? Like there's usually a physical reason. And when people do express them and go to medical professionals, they do always first and foremost start from where is the medical basis, right? Like I want to help this patient and I'm going to look for all the avenues possible that I can for the physical source of this pain, whatever it is that they're going through. And then after, like often it takes weeks, like potentially months, like take a really long time. They've really used all of their avenues. Then they go to this. Yeah. They don't want to diagnose someone with this.
So this can just happen to anyone. There's like no predisposition to this. So.
Well, like we've mentioned before with all the somatic symptom disorders, like people who have high stress, who aren't acknowledging that stress, people who have potentially a history of some type of physical illness that they've had in the past, other mental illnesses. Again, the psychoanalytic way of thinking would be like people who are less evolved in their ability to understand their conscious. People who don't get a lot of attention and maybe have some personality stuff going on. But yeah, kind of like anyone can have any mental disorder. It could happen to anyone, but it's not likely. Like these are all like really not very common. Okay. Hold on a second. Let me just write. Oh crap, now I'm blanking out. This half of the class, I'm not doing well with names. Sorry. Okay. Alrighty. Let's move on. Oh, we're good. Okay. So like you have here, you can see that this is only found, okay? Like this is real small, okay? In 5% of people referred for treatment at neurology clinics. So it's not just like 5% of the population, like that's far from it. It's only 5% of people who even go to neurology clinics. That means 95% of the others had some physical source for the neurological issues that they were experiencing. Highest estimates for in the population have been at 0.005%. So very, very small. So do not go home and worry that you could like one day just drop from a seizure with no reason. Again, patients who are like medically unsophisticated do tend to have this. We did see that they were sometimes more common in the military, and that could be, this was like back when there was a draft, and that they did find like some type of source that would say like people weren't really wanting to go through with their military training or the experience, whatever they were being deployed for. So they would, all of a sudden have some of these neurological symptoms that weren't really based on anything physical, but really it was probably stemming from that extreme anxiety that they weren't recognizing or, were in their subconscious experience. Yeah, so that's that. Most commonly occurs between early adolescence and early adulthood. So y'all are almost out of the sweet spot. So even if you were worrying, you're like, almost got it. Don't worry. Okay. Again, like I've mentioned, these conversion disorders can be connected to that attention-seeking behavior. So with, those causes, you can see the primary gains, which would be that they are escaping something that they don't want to do, that they were, feeling a lot of stress and anxiety, and then all of a sudden, they don't have to do, whatever it is that they weren't doing or that they were finding to be stressful. I don't know if I'm remembering this correctly. Does anyone watch Grey's Anatomy? Okay, so have you gotten to the part where there's like this one resident who's like super, super stressed out? And then she like all of a sudden has these physical symptoms?
Yes, when her eyes started
Yeah,
going back and forth.
okay.
I just watched
Oh, so I don't wanna, I'm not ready.
that. No, you're good.
Okay.
I got to the shooting part.
Okay, great. So she's like super stressed out. She's got a high stress job. She's not sleeping a lot, right? And then she's like, help me. And they like roll her up to the psych floor, right? Because they've like looked for everything. They couldn't find any. And like they were exhaustive in their search, of like what it could be. And then like roll her up and like, I don't know if this, I wouldn't say it probably sets on as quickly as you see in the show, but you see like relief on her face. Because, that primary gain that she was getting as far as like not having to do whatever residency work she had to do, was filling that need for her. And I guess also being in a psychiatric floor still fills that need. And that gets support that people need. So that's good. And then the secondary gains could also be, financial assistance from people that like you love or that love you. As in like they let you stay in their house and they didn't before, or they, make you food and they didn't before. Like people care for people when they have physical illnesses that are pretty extreme or problematic. So those are the secondary gains. And again, that's where the attention would be. Yes. So the primary gains would be like that immediate, I'm getting out of whatever I need to get out of. Like that stress, you're getting away from it, you're avoiding it, you don't have to do it anymore. Maybe it really was taken away. Whatever responsibilities you might have. Yeah. Can you tell me? Adrian. Any other questions on these? Again, though, even though you do see these gains that people experience, like they really are having a seizure. They really are experiencing pain. They really can't move their arm. Like it's not to say that they aren't having these symptoms and they can just like then think their way out of it and not have a seizure again. Like it takes a lot of therapeutic work to help people with this disorder. So that treatment, like I said, it's not just like you tell someone it's all psychologically based and then they don't have this pain or they don't have, the tic anymore, whatever it is. You really do have to do the cognitive behavioral work as far as treating it like a pain disorder. Yeah.
Like maybe stress or trouble with like a past trauma or abuse or something like that can manifest into conversion disorder.
I mean, you can see always whenever there's a trauma history, you're just gonna have risk factors for basically everything. So yes, I wouldn't say that this is the top choice for like if you're meeting someone with a trauma history, like it's not like your top worry of like they could develop conversion disorder, but definitely could be linked. Definitely. Yeah. So that's what you would see. So you treat pain disorder as well as conversion disorder. Pain disorder is just people who feel pain, and again, they don't have a physical reason for it. So you treat it with cognitive behavioral techniques, like we had mentioned in that previous slide, starting out with like that mindfulness and having, self-talk, visualizations, all those different options is the way that we would treat this as well. And that you have listed here as well. So we could also do for conversion disorder the hypnosis because I don't do hypnosis. That like takes a lot of additional training. But with hypnosis, getting people into a hypnotic state, talking to them to their subconscious, and talking to them about maybe what that underlying stress is, what those gains are that they're experiencing, how they can get those gains in other ways while they're in that hypnotic state can be very effective for decreasing the symptoms of, physical symptoms that they're experiencing with conversion disorder. What we also see just with problem-solving therapies as far as like, all right, like down and dirty, like what is the problem you're experiencing? Like just behaviorally trying to treat like, okay, you're stressed out about your residency program, whatever it is, like let's go talk to the head resident or your boss or whoever it is and like problem solve. Like what can we do to change something in your life that's clearly stressing you out, that's gonna make it better pretty quickly if we relieve that stress for you. So try to do that as well. Okay. So now talking about fictitious disorder. Let's watch the video and then we'll talk about it.
In one of law enforcement's most bizarre and baffling crimes, video cameras are helping save the lives of victims too young to speak out for themselves. In these disturbing videotapes, infants suffer but ultimately survive, while the footage becomes an education tool for Special FBI Agent Larry Brubaker.
For 3 or 4 hours, this is the most caring, loving mother you've ever seen. And then, just like Dr. Jekyll, Mr. Hyde, something happens and the person becomes an abuser.
The strange crime is called Munchausen syndrome by proxy, when parents secretly make their children sick to gain attention or sympathy for themselves. Assigned to the Minneapolis Bureau, Brubaker became the FBI's Munchausen expert after helping a local hospital investigate a suspected case. Now uses these videos to educate others. In this surveillance video, medical staff leaves a suspected Munchausen's father with his baby. When he's sure he's alone, the father puts the child in its crib, then smothers it until it loses consciousness. After running for help, the father feigns concern, basking in the attention. This parent was convicted of abuse and separated from his child, one of several hundred Munchausen's cases uncovered in the U.S. each year. Munchausen parents not only smother their children with their hands or bodies, they also introduce harmful bacteria into their feeding tubes, and even tamper with their medication or poison their food.
Yeah, so pretty crazy stuff. I was looking at your reactions and it is shocking and appalling to see what people do. So this, the DSM term is fictitious disorder. What we usually say in regular nomenclature is Munchausen syndrome by proxy. I don't know why we call it Munchausen syndrome by proxy, but we call it in the DSM is fictitious disorder. And like you just saw, it is when someone voluntarily, right, like they didn't know what they were doing, they were trying to make that other person, whether that's their child, it could be a spouse, it could be someone usually that they're close to. Most people who are old enough probably would not take that type of abuse, but it can happen. But it usually has to be someone that they're pretty close to and has a lot of access to, and that you can produce those psychological or physical symptoms in that other person. Whether that's because you're tainting the person's medication, you're poisoning them, you're, making them lose consciousness, whatever it is, they are making it happen. Again, they are trying to get that attention. It really is a very attention-seeking disorder. It can also be that someone is intentionally producing psychological or physical symptoms in themselves. It doesn't have to be on someone else. A lot of times it is, but it doesn't have to be. And again, it's just for the exact same reasons of like playing that sick role, getting attention. But in that case, they are intentionally, like they know what they're doing. The big difference between any of the somatic symptom disorders, conversion disorders, any of them, is like they have, no idea that this is psychologically based. Like they want to get help. They do not want to be sick. They do not want to be feeling these symptoms. Like psychically, that's what they're thinking, right? But then for someone with fictitious disorder, they are thinking thoughts that are like, okay, if I take this and if I make myself sick, maybe so-and-so will like me again, or so-and-so will pay attention to me, or so-and-so will love me, whatever it is. Yes, John.
So the parent makes their own baby like sick or lose consciousness so the parent can get attention? Like,
Mm-hmm.
okay.
Yeah, that's pretty messed up, no doubt. But I mean, you can think of maybe someone you know in your community, of someone who really does have a sick child. Like the parents do get a lot of support. The parents do get a lot of attention. People feed off that. Yeah.
I know there are like a couple of like movies where there are kids that like have an actual sickness, but then they come to find out that they don't have a sickness, and their
Oh,
parents
really?
were the ones that were.
What's that movie?
I know there's one. It's more of like a love story. What was it called? Oh my gosh, what was it called? Yeah, everything. And then there's another one that's coming out on Hulu that's like about an actual case that happened where her mom was literally like making her sick.
And then she,
And then her mom what?
nothing.
What was it called?
I can't remember. Her last name's Blanchard, but I can't remember. I watched the documentary on it, like the actual documentary. She puts her in a wheelchair and says, "Okay, don't walk." Like, really has to like.
And then she like ends up having.
And the mom has fictitious disorder?
Yeah.
Yeah.
Because the girl's like 19 and she thinks she's 7.
Mm-hmm.
It's really, really messed
Oh,
up. I need to figure out.
so sad. You can Google it and tell us if anyone's interested. Because, we love watching kids and stuff like that. You're all like the psych majors. But that's a really good rep. Thank you. Okay, whenever you find it, let us know. Any questions on this? Yes.
Is there any treatment, or is it kind of just like whatever happens kind of stuff? Like there's not really anything that they can do
Well,
about
I mean, it needs to be found, right? Like, so that's first and foremost. Like, these kids really are having terrible physical symptoms, especially if, like, they're being poisoned. Like, then it's really hard to find because they really do have a physical source for whatever is going on for them. So that's number one. Hard to catch. And then once you do, like, you have to separate that parent from that child immediately. Like, this is very extreme abuse. And then, I mean, the parent's probably going to be prosecuted. Hopefully, whatever jail time or whatever consequence that they receive does have some rehabilitation to them, to it, but I don't know, probably not. And then the child, hopefully as they're separated from their parent, the physical symptoms will decrease because they're not being suffocated, they're not being poisoned, whatever it is. But the potential psychological effects, can be very long lasting, just like with any abuse. So definitely has to be treated.
It's called The Act.
The Act, you found it too?
Yeah.
Thank you,
I
but
watched the actual documentary. It's called Mommy Dead and Dearest.
Mommy Dead and Dearest?
It's a really good documentary.
Ooh, good.
Very much.
Probably is real messed up. Tristan? Yes, John?
So it seems like that disorder is hard to actually identify. So it's like
Yes.
curious of how they got to a point where they put a camera in their places.
Right, so maybe they have like some suspicions, like you can watch maybe their reactions to when their child is sick is like a little off.
Okay.
Or like the medical professionals are like, there's no reason that this should be happening again. Like we gave the medication, and the child should be getting better and they're not. And then that could be like, oh, maybe the parents aren't giving the medication. You know, you could kind of think like that. Usually, I mean, I would say all the time, but I never want to say all or never. I would say all the time it's medical professionals who are going to be picking up on this and then making a referral to a psychologist. You are not going to find someone with fictitious disorder who is making their child sick come in to a psychologist and say, please help me. Like, you're just not going to see that. I'd be very surprised. I mean, never say never, but I'd be shocked. Yes,
So
Ruth.
So it can be by proxy, but it can also be someone doing it themselves.
Mm-hmm.
So do you know which one is more common?
Let me look at my notes. Do I have it in here? No, I don't know. Does anyone want to Google it real quick or know it? I don't know which one's more common.
I feel like it'd be more common to inflict it upon themselves.
Yeah. What?
I was thinking the opposite.
I really don't know. That's such a good question. Does anyone know? Does anyone want to do a quick Google? Which one's more often? Which one's more common? Are you looking? And tell us. Sorry, I don't know that answer. That's a really good question. Let us know. Yeah, Kenneth.
I know we're going over things that are very, very profound.
Mm-hmm.
For this to actually have a disorder, it has to be more common than believe. But what is the
Right. You would want to think no one would ever do this to their child.
what is the treatment for the person that has this particular disorder? Because I mean, if they're looking for seeking attention and all that, or going through steps with their child, what's the actual treatment for them? I mean, treatment taken a kid away to make it so the other ones doesn't fix that.
No, it doesn't fix them. I mean, it helps the child get better. But like any of these, really, the one that you want to be using most often is cognitive behavioral therapy. Like I said, people with this are probably going to jail first. If they get caught and they've done something like that, because that's just what happens to abusers, as they should. And then, you know, you kind of treat it like any other malingering. Malingering is lying. And you deal with like those external incentives of like, okay, this was attention seeking. Like, what were the types of thoughts that you were having that were saying that this was a good idea? And then, like any other cognitive treatment, you kind of like break down those thoughts and be like, this is why this is super twisted. And when you ask these people, they probably would not say, yes, I wanted to hurt my child. It's just that they were valuing, I mean, they probably weren't thinking of it this way, but they were valuing themselves over their child, and helping them see that. But sometimes, you know, people just can't be helped. Sometimes people don't change. And then, you know, they are the way they are, and hopefully they don't have more kids and don't do this again. So, yeah, unfortunately, cognitive behavioral therapy doesn't always work, but it is our best shot for this. So what you have here also, you want to, you know, be talking about those tangible external rewards that they're experiencing, address them as far as this is not the way you want to be seeking attention, this is not the way you want to be receiving support. Help them to understand the effects of their choices, whether that's on their own physical bodies, right? For someone who's maybe making themselves sick, or making someone else sick. So like talking about like causes, effects, and consequences can be very helpful, all from that cognitive behavioral lens. You know, addressing those thoughts, talking about what behaviors they're doing because of the thoughts that they have, and helping them to see that the consequences of those behaviors are not really what they want. They're not really getting what they want. It's not a very healthy, adaptive way of moving about the world. Yeah. And again, you know, for fictitious disorder, it's just really important for y'all to know it's the conscious intent. Like they really are conscious of what they are doing. I know I said that in relation to, you know, remembering back to any of the somatic symptom disorders. There's no conscious intent for the symptomatology that they are experiencing. With fictitious disorder, there is.
When you say conscious awareness, is meaning like they know that they are attention seeking, or do you think they're just doing it like, you know, how can I say this, like, they know that it's abnormal, or like,
I don't know if I would say they know it's abnormal, but I would say that they are thinking through,
to just.
I am choosing to pop these pills that I know are bad for me, and I know that they are going to make me sick, right? Like they are doing something that's gonna make them sick. They are choosing to bang their head against the wall and say that they fell on accident so that they get that attention. They're choosing to smother their child, right? So like there's that thought of saying like, yep, I'm gonna do this. When someone with the somatic symptom disorder, it's like, just happens, right? Like that conversion disorder, they just drop whatever it is. Yeah, does that answer your
Oh,
question?
yeah.
Okay, cool. Here you have just trying to further distinguish between somatic symptom disorders, because it can get pretty complicated. As far as wanting to distinguish between a conversion disorder and malingering or fictitiously sick role playing. Again, it's about that conscious intent. In other cases, it can be more difficult to make the correct diagnosis because people are really good thinkers. And again, you need to have a medical team that is also helping you with this, right? Like you can't just do this alone. So it is really a difficult diagnosis to make. Okay, so before we move on to dissociative disorders, which are different than all the somatic things we were just talking about, we're going to take our break 5 minutes early because this is actually a better stopping point before jumping in. So it is now 10:09, but it will be 10:10 in just a minute. And oh my gosh, I've like, spring break gets you off. I give you 15 minutes, or I give you 10 minutes.
20.
I do not give you 20.
It's 10.
It's 10? Okay, thanks, y'all. Come back at 10:20.